I work together with the obstetrics team at Emory University Hospital Midtown, and I see on my daily practice, this is interesting and a good portion of my clinical practice. So we're gonna start with the polling. So I have a question for you, just to think of, and where I'm gonna resolve this question, and we're gonna talk about this throughout the talk. So which of the following medications should not be used during pregnancy? Let's start the poll now. We'll give you some 15, 20 seconds. Okay, so I'm not going to answer this question now. We're going to talk about this toward the end. I just wanted to show you their answers, okay? Those are the results. We'll talk about that later. And the second question that I have for you is, in the presence of a mechanical valve during pregnancy, which is the anticoagulant of choice during the second trimester? Start the polling again. This is during the second trimester. Great. Okay, so I'm going to leave it like that. And again, we're going to go over this couple of questions towards the end. Okay, so let's start. So I'm going to talk to you about the current maternal mortality data. I think it's important in the United States, and this is the main reason why we are talking about this topic here today. What are the most common cardiovascular-related complications of pregnancy? I'm not gonna go over details about the scoring systems to stratify pregnancy risk, because our previous speakers already talked about it. Dr. Schimmer already talked to us about that, the scoring system. But we're gonna talk about implications of cardiovascular-related complications of pregnancy in the women's future cardiovascular health. So let's start. What are we talking? What is important? What is relevant talking about cardiobstetrics? Unfortunately, we know that cardiovascular disease complicates up to 4% of pregnancies, and that is excluding the hypertensive disorders of pregnancy that are even more common, and they complicate about 10% of pregnancies. Hemodynamic changes during pregnancy represent a burden to the maternal cardiovascular system, and many times, unfortunately, they provoke or exacerbate cardiovascular disease. Heart disease, that's what we're talking, that's what is so relevant to be aware, to create awareness, is the leading indirect cause of maternal mortality in developed countries, achieving up to 26% of US pregnancy-related deaths. Cardiovascular disease is the cause. And fortunately, 3 out of these 5 deaths are preventable. Women in the United States have higher risk of dying during the pregnancy and postpartum period more than any other industrialized countries. And the risk factors include, and as you can tell, these risk factors are prevalent in our society, and they are rapidly increasing. It's increasing maternal age, obesity, hypertension, diabetes, and this is increasing our women in our pregnant population. What are the data? And I'm just going to speak briefly about the numbers about maternal mortality and morbidity in our country. What is the definition? But what is the definition of maternal mortality? The definition is the death of a woman while pregnant or within 42 days of termination of the pregnancy, irrespective of the duration or the site of the pregnancy, from any cause related or aggravated by the pregnancy, and is not from any accidental or incidental causes. That is the definition of maternal mortality. As I mentioned before, unfortunately, the United States, believe it or not, is the #1 industrialized country with the highest maternal mortality. And we failed. There was a project in which the industrialized countries came together, and they generated the United Nations Millennium Development Project. And the United States failed to achieve the goal that was to reduce by 75% maternal mortality by 2015. And the estimated maternal mortality in each state has been steadily increasing. And this is a graph. What is this? This is a graph how the trends in pregnancy-related mortality have steadily been increasing. And this is the same graph just to show you how, and as we mentioned before, unfortunately, African Americans, there is a disproportionate increased risk of mortality, maternal mortality. So what are the risk factors for cardiovascular disease during and after pregnancy? One of them is the race that I just mentioned. Unfortunately, Black women have 3 to 4 times higher risk of dying from cardiovascular disease compared to white women. Age, as we heard earlier before in the previous talk by Dr. Schimmer, age also increases the risk of heart disease-related maternal death. Those women older than 40 years old have 30 times higher the risk of dying compared to women at age 20. Hypertension, hypertensive disorders of pregnancy affect 10% of the pregnancies, and hypertensive disorders of pregnancy, including preeclampsia, gestational hypertension, chronic hypertension, increases the risk of myocardial infarction by 13-fold, heart failure by 8-fold, compared to healthier pregnancies. And obesity, which is steadily rising in our society, increases the maternal death due to a specific cardiac cause. And this risk increases by the presence of obstructive sleep apnea. So this is the outline what we're going to talk about today. We're going to talk about congenital heart disease during pregnancy, arrhythmias, cardiomyopathy, and vascular heart disease. Also, aortic dissection, specifically in patients with Marfan's disease, Marfan's syndrome, bicuspid aortic valve with aortopathy and Turner's syndrome, venous thromboembolism, hypertensive disorders of pregnancy, and myocardial infarction that, although is rare, is increasing in frequency. I'm going to briefly touch on this in estimating the cardiovascular pregnancy risk. General predictors of cardiovascular disease, Dr. Schimmer showed us before. Basically, these patients should go and see a cardiologist that has a focus on pre-pregnancy risk evaluation. And those patients have to undergo a cardiac history, functional capacity evaluation, and ventricular function evaluation with echocardiogram, with electrocardiogram. And these large pregnancy cohorts were assembled to develop indices that predict the risk on these patients prior to pregnancy. And the more common, the one that was initially used or created was the CARPREG. Subsequently, the Boston Adult Congenital Heart and Sahara scores were created. However, these scores were not complete, and the one that we're using now is this in which we classified the modified WHO organization classification that Dr. Schimmer reviewed that divides or classifies those patients in low, medium, and high risk, and those patients that have heart conditions in which pregnancy is contraindicated. This is a summary this is a table of this WHO classification that classifies each of the conditions into low, class 1 or low, 2, 3, and those patients that have conditions in which pregnancy is contraindicated. And again, this is just a brief summary. This is the conditions that we have to remember. Those conditions in which pregnancy, usually on counseling, are considered to be a contraindication for pregnancy. Pulmonary hypertension, the presence of left ventricular dysfunction when an ejection fraction less than 30%. Those patients with history of peripartum cardiomyopathy in whom the left ventricular ejection fraction didn't recover, that's considered a contraindication. Those patients with severe aortic stenosis or mitral stenosis, the stenotic lesions are less tolerated than the regurgitant lesions during pregnancy. Marfan's disease, in which the aorta is larger than 45 millimeters, or when there is a aortic aneurysm in which the aorta is larger than 50 millimeters, or severe coarctation of the aorta. These are the conditions that are considered to be a contraindication for pregnancy. But let's move on to talking about the hypertensive disorders of pregnancy. As I mentioned before, they can complicate up to 10% of the pregnancies. And this accounts for 10 to 16% of maternal mortality worldwide. So it's very relevant to talk and be aware about this. It starts with an abnormal placentation in which the trophoblast is invading the myometrium, and the arterioles should invade the arterioles of the trophoblast should invade the myometrium and create a low resistance circuit. However, at some point, there is development of systemic endothelial dysfunction because the placentation is incorrectly and is not carried in a normal way. And there is systemic endothelial dysfunction, there is placental hypoperfusion and ischemia with generation of local oxidative stress that creates a target systemic organ damage. Let's talk about the classification. When I talk to you about the hypertensive disorders of pregnancy, in 2017, the American College of Cardiology and the American Heart Association classified these disorders of pregnancy in 4 categories. One is the preeclampsia, that is that hypertension and proteinuria, or any other type of end organ damage. This end organ damage can be manifested by elevated liver function tests, low platelets, renal insufficiency, or pulmonary edema. So that hypertension is associated to any of these signs demonstrate that there is systemic target organ damage. The eclampsia is when it's preeclampsia plus seizures. The other category is the chronic hypertension, which is that is defined as the systolic blood pressure or diastolic blood pressure more than 140/90, that it develops before the 20 week of gestation, or that persists beyond 12 weeks postpartum. There is also the other categories, the chronic hypertension, those patients that have underlying hypertension going into the pregnancy or that is diagnosed early into the pregnancy that on top of that develop any evidence of target organ damage, which means we call them superimposed preeclampsia. Or the gestational hypertension, that is when the blood pressure is elevated, is more than 140/90, detected after 20 weeks of gestation. This is a diagram what I mentioned before about the pathogenesis of preeclampsia. There is a defective trophoblastic invasion at the beginning that leads to reduced uteroplacenta blood flow because there is not adequate dilation and modification of the arterioles that are on the placenta. That leads to a stressed placenta in which there is hypoperfusion, ischemia, there is imbalance of angiogenic factors with oxidative stress, and there is systemic endothelial dysregulation and inflammation. And ultimately, it's going to lead to what we talk about, the end organ damage, hypertension, proteinuria, edema, clotting abnormalities, or seizures. And these, of course, these patients with preeclampsia, they have there is association with fetal growth restriction, stillbirth, or premature delivery. So what are the risk factors for preeclampsia? Those patients with acute or chronic inflammation have increased risk of preeclampsia when they get pregnant. Chronic inflammation, we know that is present in obesity, in those patients with diabetes, in those patients with acute inflammation. Interestingly now, COVID, unfortunately, is included on the list. They've seen that patients with COVID have a higher risk of preeclampsia because of the acute inflammation. Those patients with poor oral health, they have increased risk of preeclampsia, urinary tract infections. Those patients with history of vasculitis, those patients with antiphospholipid syndrome, with chronic kidney disease, those patients with history of hypertension, gestational chronic hypertension before the 20 weeks, when it's diagnosed before the 20 weeks of gestation. And social factors like low socioeconomic status and minority groups, we know that they have higher incidence of preeclampsia. And one that I didn't list it here, but is very pertinent, Dr. Schimmer talked to us about it, is IVF increases the risk of preeclampsia. There is no, and that was one of my questions, and I think you mentioned that there is no known why. I've seen that many of these patients, unfortunately, they wait long. There are patients that are older, that in my experience, when I see these patients that are obese or overweight, they have another risk factors like hypertension or dyslipidemia or what we call impaired glucose tolerance, pre-diabetic. So we're assuming and we think that that's what is involved in the physiopathology of the increased risk of preeclampsia. So what is the implication? What happened to this woman? If we think before it was considered that this patient had preeclampsia, they deliver, the preeclampsia is gone, they're fine. And unfortunately, that is not the case. We know that any type of hypertensive disorders of pregnancy is associated with an increased risk of future cardiovascular risk, hypertension, diabetes, and chronic kidney disease. There is calculated that these patients have twice the risk of mortality related to ischemic heart disease compared to those women without any history of any preeclampsia or hypertension during their pregnancy. And the theory is that the metabolic stress of pregnancy and the lactation unmask underlying cardiovascular disease manifesting as heart disease, as a hypertensive disorder of pregnancy. It's not known if what came first, but at this point it's believed that what happens is that these women have an underlying predisposition, and the stress generated in the cardiometabolic changes that occur during pregnancy unmask that risk and they fail that metabolic cardiovascular stress test, and they end up developing hypertensive disorders of pregnancy. And what it has been seen, and because of time constraints, I don't have time to show you the evidence, but it is known that these patients that develop preeclampsia or hypertension during pregnancy, they have endothelial dysfunction that persists year postpartum. They have done studies of endothelial function, and they do show the presence of endothelial dysfunction even years after delivering and when the preeclampsia is even considered to be resolved. This is an interesting paper that was published in 2013, and I just got these figures just to show you how there is increased risk of all these conditions when a woman develops a hypertensive disorder of pregnancy, even even gestational hypertension, preeclampsia, eclampsia, any of those. And this graph shows how these patients that are normotensive, they are the black line, and how those patients with those conditions have a decreased survival compared to those patients that had a normal pregnancy. This is a paper that came out recently in the New England Journal of Medicine this year, how we can prevent preeclampsia. Up until now, preeclampsia is believed just to be managed by delivering the patients. We can just deliver the patient, the preeclampsia is resolved, and that is it. And then we know now, and I'm going to mention this, that these patients need ongoing care after that delivery. However, not much is known about how we can prevent preeclampsia. We know it is considered that there is a reduction by 40% with moderate exercise, consider more than 140 minutes of exercise a week. It's important to know that the gynecologists, the MFM doctors, and us, the cardiologists, we don't recommend women to start exercising dramatically if they haven't done it even before pregnancy, but we do want them to, if they've been active, to continue that activity, and if not, just to do moderate walking exercise on top of exercise more than 140 minutes a week, because now it's shown that it helps reducing the risk of preeclampsia. On those patients that have a higher risk of preeclampsia because they have history of a previous pregnancy with preeclampsia, or they have any of the risk factors I mentioned before, we know that aspirin, starting before the week 16 of gestation, does reduce the risk of preeclampsia by 60%. However, aspirin has been shown to reduce the risk of preterm preeclampsia, because it's different when they develop preeclampsia at term or postpartum than when they develop at preterm. And aspirin works specifically more in reducing by 60% on preterm preeclampsia, more than 100 milligrams of aspirin a day. There is also modest evidence that dietary calcium also helps preventing preeclampsia. These are the values that they recommend for a daily consumption of calcium. And time birth, that's what these patients get deliver earlier. When there is a patient with history of gestational hypertension or chronic hypertension, these patients are usually delivered before the 39 weeks of gestation, but there is a mild reduction on the risk of preeclampsia if these patients get delivered between 37.6 days or 39 weeks of gestation. Unfortunately, there is disappointing data that statins and folic acid initially were believed to reduce the risk of preeclampsia, but they don't. How do we manage hypertension during pregnancy? The ACOG, the American College of Gynecologists, has a document in which goes over the specifics of when the thresholds in which you should start treating hypertension and the medications that are preferred. And I'm going to summarize and just go through some few points here. The ACOG, up until now, recommends a therapy of patients with hypertension without end organ damage. So that patient with plain hypertension, normal renal function, not other evidence of end organ damage, to treat them when blood pressure gets higher than 160/105 millimeters of mercury. Why? Because there was no evidence that treating to a lower goals made a difference in outcomes. And on the other hand, there was concern for damage to the baby. So that has been the ACOG recommendation up until now. Also, it was believed, and I'm going to talk about this, that up until now, the evidence had shown that antihypertensives did not reduce the risk of preeclampsia, but did reduce the risk of complications on the mother, like a stroke. So if you left a woman with a blood pressure of 180, of course, that risk, the risk of a stroke is reduced by treating hypertension, but there was no evidence that it reduced the risk of progressing to preeclampsia. On patients with a blood pressure, this would be the goal of the blood pressure. However, on those patients with end organ damage, the goals would be lower on the 120s over 80s range. And what happens is that the placenta, the theory behind not dropping the blood pressure too much is that the placenta does not regulate flow. So the belief is that the maternal hypotension would lead to the fetal distress and delay in growth. That's when we treat patients with hypertension and we have these goals that are lower goals in the 120s over 70s. We follow very closely the fetal growth on serial ultrasounds. And an interesting paper that I want to mention here in the Journal of American Heart Association recently, I think in March or May, was published how Mediterranean diet was associated to reduce risk of preeclampsia in Black women. And I think this is important because this gives some fundament, some hard data on our counseling when patients are pregnant, how to follow a Mediterranean diet, not only because of the cardiovascular risk, but because of the decrease in the risk of preeclampsia. And this paper, I think, is going to be practice-changing. I think this is what is so important. This study was published in the New England Journal of Medicine in May, in which the CHAP trial it stands for Chronic Hypertension and Pregnancy. It's an open-label, multi-center randomized trial that includes over 2,400 women. And they were randomized to a target of less than 140 over 90 versus a control group of less than 160 over 105, which is what we've been practicing for years. Not to be so strict with the blood pressure control. But as I said, there was a belief that it decreased the placental flow and it could affect detriment the baby. And what it shows is that the active group, those patients in which the target was lower, they had lower incidence of the primary outcome. There was preeclampsia or preterm birth, 30 versus 37%. And this is statistically significant. And what is more important, the answer to the question is, without increasing risk of the small gestational age or serious maternal complications. And I think this is very important because this actually should change our clinical practice now when we manage these patients with hypertension during pregnancy. What is the pharmacotherapy? As I mentioned before, on those patients with history of preeclampsia or at risk of preeclampsia, the low-dose aspirin has proven to have a modest reduction in risk. And what is important, it should be started early, before 16 weeks, and continue daily until 36 to 37 weeks in anticipation to the delivery. Medications, the first-line medications that are recommended is labetalol, nifedipine, and methyldopa. Second line are beta blockers and other calcium channel blockers, except for atenolol, because atenolol crosses the placenta and causes intrauterine growth retardation. So the first line is labetalol, which is a beta blocker, but the labetalol, nifedipine, and methyldopa. Methyldopa has a very, very modest effect. We don't use it that much anymore. But beta blockers and other calcium channel blockers can be used. But between amlodipine and nifedipine has way more data than amlodipine. And in case of hypertensive emergencies, hydralazine or labetalol IV are used. This is the document I was talking about, how the gynecologist and the cardiologist came together, and now this is an updated risk. We know about these traditional cardiovascular risk factors. We know about diabetes, smoking, hypertension, dyslipidemia for heart disease. Now, there are some emerging, and now that's why we're here talking about this, of non-traditional risk factors for cardiovascular disease. Preterm delivery is considered and should be taken into consideration as a risk factor for cardiovascular disease, hypertensive disorders of pregnancy, gestational diabetes, which I didn't speak today, could be another whole talk, and autoimmune disease and breast cancer and depression, of course. But this is very important. The history of pregnancies in a woman and how those pregnancies occur, how if they had any history of complications, even postpartum preeclampsia should be taken into consideration when assessing the risk of cardiovascular disease in a woman. And in 2018, in 2018, the American Heart Association and the American College of Gynecology came together and they created this document, and it's a presidential advisory in which promoting risk identification or reduction of cardiovascular disease in women should be done with collaboration of the obstetricians and gynecologists. Why? Because the family medicine, the doctors, are not delivering as many babies as before. Now, the gynecologist, their visits to the obstetrician when they're pregnant might be the only opportunity that we have to counsel these women and to detect the women with risk to decrease their cardiovascular disease risk and make interventions and intervene on these women. So that's why the gynecologists now are becoming our partners with cardiologists and primary care physicians in which identifying these patients at higher risk of developing cardiac complications later on. So now that we finished with hypertensive disorders of pregnancy, let's move into the arrhythmias. What is the highest risk of developing arrhythmia, of course, is when a woman has a congenital heart disease or has known cardiac disease. Those patients are at high risk of developing arrhythmias. And there is because now we have more women surviving congenital heart disease. They're living longer. They're living through the childbirth age, and now they're getting pregnant. That's where we are dealing with more arrhythmias now in women than before. SVT, supraventricular tachycardia, is still the most common arrhythmia during pregnancy. It's more common during late pregnancy. And the reason why this happens, and it's believed that this SVT or other arrhythmias happen later during pregnancy, is because there is increase in sympathetic activity. There is increased preload, which leads to atrial and ventricular stretch, and because of the hormonal changes that happen during pregnancy. The non-pharmacological management, of course, is the optimal, is the preferred one. However, when you have a patient with SVT that comes to the emergency room, vagal maneuver should be used first. But adenosine, metoprolol, or verapamil, which is third line, can be used. These medications, adenosine can be used in the emergency setting to control an SVT episode in women. And antiarrhythmics like flecainide, propafenone, digoxin, sotalol, or quinidine can also be used in pregnancy. Amiodarone should not be used except on code conditions in the setting of VT or VF because of the risk of fetal hyperthyroidism, because there is also risk to the fetus of prolonged QT and intrauterine growth retardation. And as I mentioned before, not atenolol because it leads to fetal growth restriction because of how easily it crosses the placenta. Let's talk about peripartum cardiomyopathy. The definition is the onset of heart failure with no identifiable cause within the last month of pregnancy or within 5 months of delivery. This is the definition of peripartum cardiomyopathy, and it's defined when the ejection fraction drops under 45%. And the incidence is variable. There are some places in the world that have a high incidence, like Haiti and Nigeria. 1 in 100 pregnancies have peripartum cardiomyopathy. In the United States, it's considered 1 in 1,000 or 4,000 live births have peripartum cardiomyopathy. And the risk factors overlap significantly with the risk factors for preeclampsia, but we know that multiple gestation, African ancestry, or the hypertensive disorders of pregnancy increases the risk of pericardium cardiomyopathy. The etiology is multifactorial. It is believed that there is an angiogenic imbalance. When there is an imbalance of the angiogenic factors like the VEGF signaling, there is altered prolactin processing. We know that pregnancy is a pro-inflammatory state. There has been involvement of cytokines like the TNF-alpha and the interleukin-6. There is also believed that there can be an involvement of an immune component where there is an abnormal immune response to the fetal cells going around the woman's bloodstream. Genetic, we know that there is a familial clustering of peripartum cardiomyopathy, and that is believed to have a strong presence in, for example, in places like Nigeria or Haiti, as I mentioned. And we have to keep in mind, I didn't have a chance to discuss with you the hemodynamic changes during pregnancy, but there is a significant increase. There is a hemodynamic stress in women during pregnancy, since early in the pregnancy, there is approximately a 40% increase in the blood volume and the cardiac output in the pregnant woman. The prognosis, 20 to 60% of these women, fortunately, they recover the ejection fraction to normal within 6 months to 5 years. However, in those women that don't recover the ejection fraction after this delivery, those patients are encouraged not to have another pregnancy because there is a significant risk for them. What is important to remember from the peripartum cardiomyopathy management is similar to patients that are non-pregnant. However, what is very important to keep in mind is that the RNAs, the ACE inhibitors, the ARBs, and the aldosterone antagonists are contraindicated. These medications should not be used in a patient with peripartum cardiomyopathy. The ICD placements should be deferred at least 3 to 6 months following the presentation. Why? Because these women can recover the ejection fraction, and I've seen it. So we don't talk about ICDs on discharge. We can talk about a life vest, but we don't talk about placing a defibrillator until 3 to 6 months later. Bromocriptine therapy in peripartum cardiomyopathy is controversial. There is preliminary data suggesting benefit, but at this point, there is no specific recommendation about it. Breastfeeding is also controversial. However, there are some studies that also show that there is no contraindication to breastfeeding during pregnancy, after delivery in patients with peripartum cardiomyopathy. And as I mentioned before, those patients that have persistent dysfunction, meaning they don't recover their ejection fraction, or if they have an initial ejection fraction that is very low, even if they recover, they are recommended to avoid subsequent pregnancies. What about, and we're going to move into valvular heart disease, patients with prosthetic valves. Patients with prosthetic valves and with native valvular heart disease. As I mentioned at the beginning, those stenotic lesions are far less tolerated because all the hemodynamic changes that come along with the pregnancy, the tachycardia, the increase in the blood volume, the increase in the cardiac output. So those patients with mitral stenosis and atrial stenosis are going to have problems during pregnancy. And they're recommended to see a cardiologist, of course, and a structural heart doctor prior to conceiving to get counsel on if they need to get intervention before getting pregnant or not. We have several patients at Emory that have needed balloon valvuloplasties during pregnancy because they have severe MS and they don't tolerate it. And these patients are usually advised to deliver in a advanced hospital, in a third level hospital, because of the close monitoring they need for the hemodynamic changes. Remember, when the patients deliver, there is significant blood volume that goes back into the woman's system, and that is going to challenge that stenotic lesion. So these patients are usually, many times they deliver at Emory Hospital Midtown, and they go to the CCU for close monitoring for those hemodynamic changes after delivery. These patients might need diuretics for congestion, even postpartum, but also during the pregnancy. We can use furosemide, we can use diuretics during pregnancy. They are not contraindicated. We use beta blockers to slow down the heart rate and allow for more diastolic filling of the left ventricle in patients with mitral stenosis. And those patients that have concomitant atrial fibrillation or left atrium thrombus or history of embolism, those patients are at high risk of thromboembolism. Those patients should be anticoagulated. What about prosthetic valves? Those patients now, as I mentioned before, now women are living longer, women with congenital heart disease that wanted to have children at a later age. So we have to deal with this. And these patients are a challenge, especially when there is a mechanical valve because of the anticoagulation. So it has significant risk. And we know that pregnancy is a prothrombotic stage. So there is an increased risk of thromboembolic events that peaks at the first week postpartum until the 6 weeks. So these women need very, very close follow-up during and after delivery. And unfortunately, there are no large clinical trials to guide therapy. We don't have, and we've been the guidelines that I'm gonna go over today have been the guidelines that we've been using for years because they are the lack of updated trials. Basically, we have to balance the risk between teratogenicity, and mechanical thrombosis that can occur up to 5% of the pregnancy. So we have to balance on the use of warfarin, because the problem is that the number one, the preferred anticoagulant agent in these pregnancies is warfarin. We know that warfarin is the most effective anticoagulant on these prosthetic valves during pregnancy. There is no studies about the DOACs, of course, so those are not an option. But we know that warfarin causes birth defects in the embryo. And likely it's dose dependent. Those women that need more than 5 milligrams of warfarin a day are at high risk. It occurs in 6% of the treated pregnancies. And the problem is that these pregnancies are at higher risk early in the pregnancy. That's what these women that we see in clinic that we have with mechanical heart valves, we need to talk to them about pregnancy, because ideally they should be counseled prior to the pregnancy, because by the time they have been in warfarin, and by the time they find out that they are pregnant, it might be too late, and the fetus may have already had effects of the warfarin therapy that the mother is getting. Warfarin causes cartilage defects due to extracellular matrix metabolic enzyme inhibition. They can lead to spontaneous abortion, to stillbirth, to CNS defects in the second and third trimesters, and into intracranial bleeding, because despite reversing anticoagulation on those women by the time of delivery, unfortunately, it does not reverse anticoagulation in the fetus, and there is increase of intracranial bleeding on these babies. This is a summary. This is a graph of what is currently recommended. This is the American Society of American Heart Association and ACC guidelines. If those patients are going to receive more than 5 millimeters a day of warfarin, they should be switched early on to low molecular weight heparin or infractionated heparin. Of course, these patients with fractionated heparin, they would have to be hospitalized. So that's why we use the low molecular weight heparin. However, we know that for the valve, the warfarin is best. But if they are getting more than 5 milligrams a day of warfarin, it's better to switch into low molecular weight heparin, especially in that first trimester, with a very, very close follow-up of the anti-10 levels on those patients receiving low molecular weight heparin. In the second and third trimester, those patients should go back to warfarin, because that's the safest, that's the best way to protect that valve against thrombosis. Then when they're getting close to the delivery, hopefully we can plan the delivery, hopefully this woman is gonna go through the end, and we switch them back to low molecular weight heparin, and then again, those patients need to have serial peaks and trough levels of enoxaparin measured to assure appropriate anticoagulation. As I mentioned before, ideally this should happen. We don't want them to deliver on warfarin, because we can revert the INR, we can revert the warfarin in women, but not in the fetus, and there is a significant increased risk of CNS bleeding. In terms of acute coronary syndromes, the epidemiology, the acute coronary syndromes account for 20% of the maternal deaths, and it is believed that it accounts for 6 per 100,000 deliveries. And these are the cause of ACS in women is different in pregnant women. We don't have number one atherosclerosis. We have first is the coronary artery dissection. That's usually the cause of the ACS in a woman, followed by atherosclerosis. Some women have thrombosis because of the prothrombotic stage of the pregnancy, and also some women just develop MI from spasms. And this is because there are changes in the vessel structure, and because of what I mentioned before, there is a huge hemodynamic burden on pregnant women. They are more common in the third trimester and the postpartum period. And those women with the traditional risk factors like obesity, smoker, advanced age, FMD, this fibromuscular dysplasia, that is more common in women, have increased risk of ACS during pregnancy and the postpartum period. In terms of management, when it's a STEMI, when it's a ST elevation MI, those patients should be rushed to the cath lab, and if they need to get a stent. Ideally, the bare metal stents, because of the unknown safety on the drug-eluting stents that we're currently using. When there is a lower risk STEMI, in pregnant women, there is an increased risk of dissection during left heart catheterization. Even just injecting the contrast, the diagnostic part of the heart catheterization can induce dissection, and that might make the things worse. So those patients with a low risk in STEMI, they are managed conservatively. With monitoring, they are admitted to the hospital. We make sure they're not having ongoing ischemia, ongoing chest pain. They don't develop arrhythmias. What happens with ejection fraction? But we prefer just to avoid heart catheterization at that point. Aspirin and clopidogrel can be used during pregnancy, beta blockers, calcium channel blockers to decrease the burden of ischemia, the myocardial ischemic demand, low molecular weight heparin, nitrates, they can be used during pregnancy. However, we do recommend holding the clopidogrel 7 days prior to delivery because of the obvious reasons of increased risk of hemorrhage. Statins, up until now, have been contraindicated. Fibrinolysis is contraindicated, of course. And when those patients that have known coronary artery disease and have had a recent MI, those patients that you have on statins, so they get pregnant, those patients some of them you're going to continue the statins, and I'm going to talk about that. But in some of the low-risk ones, you can just switch them to a bile acid sequestrants that are currently the treatment of choice for dyslipidemia in these women. These women that have an ACS, that are in the category of the non-ST elevation MI, those patients should be seen, of course, by a cardiologist in the postpartum period. And there is a recommendation for CTA or MRA of the brain and the pelvis, of the whole body, to look for FMD. What is new? And as I mentioned, the statins. What do we know about the statins? Traditionally, they have been contraindicated in pregnancy since they were approved in 1987. And because the early observational animal data, we didn't have human data, the animal data suggested that they induce more miscarriages and nervous system developmental issues, abnormalities. However, there have not been any randomized controlled clinical trials on humans. And recent human data of few registries have shown that there is no teratogenicity. In a study performed in Taiwan with almost 500 women, and in the United States, and a study performed here with over 1,000 women that were exposed to statins, retrospective data showed that there was no association to congenital abnormalities, and there was no increased risk of low birth weight, preterm labor, or low 1-minute Apgar score. This actually brings to our attention that we might be able to use statins. And at this point, it is recommended that we have the conversation with women about the risk of being taken off the statin when there is a high ischemic burden. Those patients that have had PCI that is recent, or they have significant dyslipidemia, there is place to have that conversation about considering the statin. It's not like before that they were 100% contraindicated. I think now we can discuss that with the woman and tell her about this new data, human data that we have, in which there has been not increase in adverse outcomes with the statins. What about aortic aortopathy during pregnancy? The aortic dissection, as you know, is catastrophic. It's rare, fortunately, during pregnancy, but it's catastrophic. And most of them are type A, which means that there is in the ascending aorta, that is the one that carries the highest mortality. In those patients with connective tissue disease, like patients with Marfan, with Ehlers-Danlos, Turner, on bicuspid aortic valve, those are the patients that have a higher risk of dissection. And what we have to use, this is the recommendation, the beta blockers, labetalol, metoprolol, are top on the list, and they should be used throughout the pregnancy as tolerated per heart rate and blood pressure, because we know that they reduce the stress on the aorta, and they reduce the risk of expanding the size and rupture. And the dose should be titrated to reduce the heart rate by 20 beats per minute. And in these patients, a strict blood pressure control is recommended. We don't go with a more permissive blood pressure. These patients should have a blood pressure of 120/70 during the pregnancy, and they need close follow-up. We can use TTE during the pregnancy, or TEE, or the MRIs without gadolinium, and these patients need close follow-up during each trimester of the pregnancy. Ideally, as I mentioned before, these patients should be seen in the preconceptional time to see if these patients are going to need aortic root replacement prior to conceive. So in conclusion, the pregnancy is associated with significant changes in the cardiovascular system. It puts a lot of burden, hemodynamic burden, on a woman. And in the setting of certain underlying disorders or underlying cardiovascular disease predisposition or risk factors, can lead to a variety of acute cardiovascular conditions with effects on the fetal maternal well-being. And the maternal heart disease has emerged as a major threat to the long-term women's cardiovascular health. And the pregnancy, as I mentioned before, during pregnancy, the postpartum periods offer a unique opportunity for us as a practitioners to detect that woman that is high risk of developing future cardiovascular disease, educate the woman, and apply aggressive risk factor modification. Thank you very much. Happy to take any questions.